I did a pharmacy residency with a 24-hour on-call program, and at the end of each shift, we would send out a list of all the calls we got and our recommendations in order to get feedback from our preceptors. And in order to safely send this list, we would first remove all patient information from the summaries so that, again, we could send it without worrying about violating HIPAA. Now, this was sent over secure email anyway, but again, it's going to a lot of people, all of our preceptors, so we just took out all patient information ahead of time, right? But that also means that I now have all these documents, and they're already de-identified, so let's go through one of my on-call shifts. So the shift starts at 5 p.m. and goes until 8 a.m. So it looks like right away at 5:15, I got called to a rapid response in front of the hospital. It was a 64-year-old with a whole bunch of comorbidities, type 2 diabetes, hypertension, hyperlipidemia, COPD. He had been admitted because he had a DVT and PE, deep vein thrombosis, and pulmonary embolism, and had been started on Xarelto. He had just been discharged, and then he had a syncopal episode right in front of the hospital. So they brought him back in, and he was complaining of chest pain, and he was admitted to our observation unit to be watched. While I was down there, I overheard that a critical patient was coming in, so I stuck around because I wanted to be involved, obviously. So this was an 85-year-old female who had hypertension, spinal stenosis, and COPD. She was brought in by EMS following, again, syncopal episode, theme of the night. When they got there, she was unresponsive with a blood pressure of 54/30, so bad. She got fluids and started to improve in condition and was now answering yes or no questions. So this lady happened to be visiting from New Zealand, and she had her daughters with her. So my role in this was I spoke with the daughters and I got a list of her medications, and then I translated those medications from the New Zealand version into the American version. And I remember this specifically because she was on dual calcium channel blockers, dihydropyridine and non-dihydropyridine calcium channel blocker. And I didn't know that that was a thing. And I remember looking into it and being like, oh my gosh, they actually do this. And it's kind of scary. But it is, in fact, a thing. She was taking them both, and she was supposed to be. She ended up being septic. They ended up deciding that pneumonia was the source. And she did have a penicillin allergy, but it looks like I recommended ceftriaxone because it was rash as a baby. And as we know, that means it is safe to use cephalosporins, and now we know that means it's probably safe to use Zosyn as well. At 21:48, so now almost 10 o'clock, so a lot of time has passed, I get called to a rapid response for hypotension, so low blood pressure. A 50-year-old male with looks like renal cell carcinoma, left lower extremity DVT. It was on Xarelto for anticoagulation. Kind of gross, if you ask me. The patient was having abdominal pain, jaundice, and constipation. New onset of yellowing skin and eyes. Looks like I arrived to the room to find a blood pressure of 69/38. Eek. Patient complaining of persistent abdominal pain and new onset shortness of breath. Looks like they had had 5 liters removed earlier that day through paracentesis, and also had their first hemodialysis session. So there's a lot of fluid shifting. So it looks like my role in this was I discussed with the medical residents causes for hypotension, so fluid shifts versus infection. I think we had very clear evidence for fluid shifts, but in a patient like this, you cannot rule out infection. So we decided to start broad spectrum antibiotics. Looks like they asked for Vanc and Zosyn, so I dosed the Vanc and Zosyn, and discontinued the ceftriaxone that the patient was already on because now we're starting Zosyn, so we do not need it. It looks like by the time I was leaving, the patient's blood pressure had improved to 99/55, and they went to the ICU. At 22:42, so now we're almost to 11 o'clock, I got called to a code stroke. It looks like I did not recommend TNK, and we did not give TNK. This was a 60-year-old male who had type 2 diabetes, a previous stroke. He came with his daughters, who endorsed his last known normal was an hour before this, which means He could have gotten the TNK. He's within the 4-hour window. However, while we were in CT, it looks like all of his symptoms had resolved. He was back to baseline, and so therefore we did not administer TNK. That was a TIA, transient ischemic attack, so like a mini stroke, and that is a contraindication to getting tenecteplase, the clot busting medication. It looks like at 23:11, so just after 11 p.m., I got a call. I have a patient with MSSA, so methicillin susceptible Staph aureus bacteremia. Urine culture is still pending. UA looks kind of gross. What can I use to cover both? So this is a 64-year-old female, ESRD, CKD, transplanted kidney, hypertension, type 2 diabetes, and looks like she had been in the ICU for infection, now was doing better. Allergies, penicillin, of course, but had tolerated cefazolin in the past when I looked. Lots of other information. Looks like I recommended an ID consult, of course, because it's a transplant patient. I had recommended starting on Ancef, cefazolin, 2 grams every 8 hours for MSSA bacteremia. I then recommended asking the patient about urinary symptoms because we don't need to treat asymptomatic bacteria, especially not in the middle of the night. However, this is a transplant patient, so meh. Looks like the patient had Enterobacter in the past, which wouldn't be covered by Ancef. So I recommended, if they wanted to treat both, to do, IV Bactrim. That's disgusting. I would not recommend at this time. Looks like in the morning I saw that only Ancef had been started, and they decided that was sufficient. At 11:30, I got a call. I have a patient who is very agitated. She got haloperidol, 2 milligrams intramuscularly around 9 o'clock. Should I hold her evening quetiapine? I don't know why we would hold her evening medication if she's already agitated. Oh my gosh, this is taking so long. It looks like I got paged again. I was at an RRT and they said that she actually responds well to olanzapine and she's very agitated. Should they give the quetiapine now? And I said, you know what? Hold off. Don't give the quetiapine right now. Instead, give 5 milligrams intramuscular olanzapine. And then it looks like I noticed that the medical resident had stopped the patient's Dilaudid that the patient was on because she had, looks like some sort of significant wound dehiscence and a surgical site infection. So a lot of reason for pain, and had stopped her Dilaudid due to concerns for sedation. So I recommended, instead of hitting her with the olanzapine and antipsychotics, perhaps we treat her pain. And then it looks like per chart review in the morning, patient was not given any additional antipsychotics and instead was given a dose of Dilaudid around 2 a.m. and then another dose around 4:30. So looks like they did not need antipsychotics. She just needed her pain treated. Wow. At 1 a.m., a patient with BV that was refractory to Flagyl. They want to order Clinda gel, but they couldn't find it. Helped them order that. I have a patient with acute cholecystitis. He isn't septic, but he has been hospitalized for a month. Can I give him Zosyn? I said, sure, give him Zosyn. And also advise that they hold the prophylactic Cipro that the patient was already on while they're on Zosyn. Oh gosh, I'm running out of time. Patient with a PE, they wanted to start Lovenox, but the patient's 120 kilograms. Is it okay to do 120 twice a day because they had never used over 100? And looks like patient had adequate renal function and no obvious risk of bleeding, so I did recommend they give that high of a dose. I don't know that was the right call at this time. Again, I was a resident. Looks like Vanc trough came back at 45 at 4 a.m. That was probably a jump scare, but dose had already been held. There was an RRT called at 5:45. Looks like shortness of breath and hypertension. Visibly diaphoretic. I didn't end up doing anything. Oh God, I'm out of time. that was the night.